So, good afternoon, everyone. My name is Kwame Shanaube, and my co-chair here is Fen Terris. Would like to welcome you to our session, Taking HIV Testing to the Next Level. So we have 5 great presentations, and we're looking forward to a great session.
Thanks, everyone, for coming. So our first presenter is Damien de Valk from the World Bank. He's a senior economist in the Development Research Group, focusing on health economics and HIV in particular. And I think we probably know him for his work on incentives, and here he's going to come and talk to us a bit more about incentives. Without further ado, Damien.
Thank you very much. Good afternoon to everyone, and it's a pleasure to discuss with you the impact of performance-based financing on the delivery of HIV testing, on prevention of mother-to-child transmission, and antiretroviral delivery in the Cameroon health system. So, results-based financing that we usually called RBF is a cash payment or non-monetary transfer made to a national or sub-national government, manager, provider, payer, or consumer of health services after predefined results have been attained and verified. And that's an umbrella term that encompasses various types of interventions that target beneficiaries, for example, conditional cash transfers, but also providers. And the example then is the one that we are going to look at, performance-based financing. And in practice, what happens is that there is a contract that is made between the government and the health facility with a list of bonuses, and the health facilities is paid for every of these health services that are delivered. As well, there is also a modifier for quality. So we pay both for quantity and quality of service delivered. In our impact evaluation here, we try to look into the performance-based financing PBF black box by basically looking at different components of performance-based financing. The first group that we will call T1 is the performance-based financing group itself, with performance bonuses that are provided to health facilities based on the quantity and quality of the services that they are providing. In the second group that we will call C1, the idea is to look whether it's the incentive and the paying condition on the quantity of services that makes a difference, or just the money. So what we are going to have is the same amount of financial resources as in the first group, the PBF group, but not linked to performance, with the same level of supervision and management autonomy as in the PBF group. Our third group that we will call C2, there is no additional money, but we look at we introduce the same level of supervision as the PBF group. We want to know whether maybe it's not the conditioning, it's not more money, it's maybe just enhanced supervision that does the trick. But we know that these facilities do not have management autonomy. And finally, the last group is the pure control group, where it's the statu quo, it's as it was before. So here is a table that describes more in detail what the components of each group. I will not go over all the details. So if you remember that the main difference between the PBF group, the first one, and the other one is everything the same, including the amount of money. But in the first group, the amount of money is conditioned on the quantity and quality of service delivered, whereas in the second group, it's basically the average of what the other facilities are getting. Okay, so it's on average the same amount of money. In C2, there is no additional money, but there is enhanced supervision the same as is before. but no management autonomy. And finally, C3 is all statu quo. So there is a list for a lot of services with a price. And here I have reproduced the prices in CFA francs, and $1 is about 500 CFA francs, for the 3 services related to HIV. The list is much bigger and includes a lot of services, mainly in maternal and child health. Okay, but here, so facilities that are putting HIV-positive pregnant women on ARV, prophylactic treatment, according to the national protocol, will receive 7,000 CFA francs or $14. Okay, same for the babies that are born of HIV mothers, HIV-positive mothers, and who are placed on PMTCT protocol. It's also 7,000 CFA francs or $14 US. And then for voluntary counseling and testing, for each person who came to the health facility for HIV/AIDS and was tested, it's basically $2. Okay, so that's the list of price. Then there will be a modifier for a measure of quality of care in the facilities, but that's basically all the bonuses that are received in the PBF are calculated. So we did a randomized impact evaluation with a public randomization ceremony, and all heads of the health facilities in the evaluation districts, in these 3 evaluation districts, were present to see whether their facility would be in one of the 4 groups that I just described. So in terms of methods, so I mentioned this is a prospective randomized impact evaluation, and 200 primary health facilities were distributed randomly into these 4 groups, all the public health facilities in this region, plus a sample of private health facilities. All the hospitals that are above these primary healthcare facilities, they received the PBF. So they had the full contract, because we thought that since they are the supervising hospital, they need to be under the same type of incentive as the facilities under them. We did a set of health facility survey and household survey, both at baseline in 2012 and at endline 3 years later. I'm not showing you, but we had good balance across the 4 study group at baseline, both in the indicators from the health facility survey and the household survey. So that means we can trust the randomization and look at the difference at endline to see what are the impact. And I'm coming to the results. As I said, I will focus, because of the topic of our conference, on this incentive for HIV services. But I'll give you a quick snapshot of the other result on maternal and child health, so that you see a little bit what's going on. We have some positive results in green, but we don't have them for 2 types of services that we really wanted to move, which were antenatal consultations and deliveries. But we see for the group T1, which is PBF, and often also for the group C1, which is additional money but not linked to performance, we see positive impacts for postnatal consultation, the uptake of modern family planning, the vaccination with the polio 3 pentavalent 3 vaccine, as well as vaccination for tetanus for pregnant women. Okay, and so we conclude from this, before going to the HIV results, that there are positive impacts, but not for all services. And those positive impacts are mainly for the first 2 groups that bring additional money. And there doesn't seem to be a big difference whether or not you condition that money on actually counting and measuring the number of services that are provided. Okay? And on the other hand, this group C2, that basically focused on providing more supervision but not additional money, we see no difference with the control group. All the comparisons here are with the control group. Now let me move to the 3 HIV indicators that are mentioned before and start with HIV testing. And here we see, on a monthly basis, a fairly large increase in the number of people that are tested for HIV, both for the PBF group and for the first control group with more money but no conditioning of the incentive. We see, for example, for the PBF group, that means 61 people on average were coming, more people were coming every month. That's from a baseline of 9 people per month, so it's a huge increase. And this increase is also there for the group that receives additional money, a little bit less, but it's not statistically different. So for HIV testing, for these $2 that were given for additional HIV testing, seems to have worked well, okay? But we see no significant impact for the 2 other indicators that were incentivized. The prevention of mother-to-child transmission, nothing is significant there. And also, we don't see it for the uptake of antiretroviral treatment. We see that's the first coefficient that there is an increase over time, but that's the same in the 4 groups. So it's a little bit surprising that, you know, when you incentivize and give $14, you see no impact, and when you give $2 for HIV testing, you see an impact, but we think it's just because the occurrence of pregnant women in Cameroon, which is not a country with very high HIV prevalence, the occurrence of pregnant women coming with HIV needing to be put on the PMTCT protocol is so infrequent that probably, even though the incentives were high, we were not powered to see a statistically significant difference. I'll conclude here by just summarizing the results. We introduced this huge reform in the Cameroonian health system, where we set up a system of incentives to provide more and better quality services, a long list of maternal and child health services. We found positive impact on not all, but some indicators. And on HIV, it was mainly on HIV testing. And in general, we didn't find that very carefully linking the payments to the measure and the counting of the indicators made a difference compared to just increasing the budget with an equivalent of money and giving the managerial autonomy to the facilities. And it is, I'll conclude here, and if you have questions, I'll answer them at the end. Thank you.
Please kindly hold your questions. What we'll do is we'll have the questions for the presenters right at the end of the session. So our next presenter is Flavia Bianchi. She is the Strategic Information Technical Advisor at EGPAF, responsible for developing and implementing the M&E system for the Point of Care Early Impact project. Flavia, please.
Thank you. Good afternoon. I am so pleased to be here today to present the pre and post evaluation results of POC EID, Point of Care Early Infant Diagnosis for HIV in 8 sub-Saharan countries. I thought I would start by just reviewing some of the challenges we face with EID to better contextualize the potential benefits of POC before moving on to just review quickly EGPAF's strategic approach to product placement and program implementation. Then moving on to our evaluation methods before presenting our very exciting results and what they mean for closing the diagnostic gap. This might be familiar to some of you. When we consider the timing and potential for POC EID, we want to consider the 3 main challenges that we face in sub-Saharan Africa. The first challenge is poor access to and delays to testing. The 2016 data from UNAIDS shows that only about 50% of infants are tested for HIV by 2 months of age. The second challenge is delayed or no return of results. We looked at the literature for our project, and we saw that the median turnaround time from blood sample collection to receipt of results by a caregiver was anywhere between 30 to 90 days. Then you add on top of that the fact that only about 50% of results are actually reached by the caregiver, which inevitably leads to our third challenge, which is poor ART initiation. Again, UNAIDS data shows that only about 50% of HIV-infected kids are initiated on treatment. In 2016, the WHO released some guidelines that spoke to the potential benefits of POC in terms of specimen handling and reducing the turnaround time to receipt of results by bringing the test closer to the patient. At the time, they requested more research, more information to get a sense of the impact of POC on patient management, treatment, and infant outcomes. And so here we are today. In 2015, EGPAF received funding from UNITAID to implement POC EID in 9 countries that we see here in my map. Our selection of sites and placement of platforms was very strategic in nature. We considered human resources, facility preparedness, testing needs, location, etc., always working in very close collaborations with the Ministry of Health. We implemented a phased approach, starting with a 6-month pilot phase that involved very close monitoring at the site level, and then we scaled up across the country. Because we wanted to reach as many kids as possible, we also implemented a hub-and-spoke testing network, and we accepted tests from multiple entry points. And here's just a bit of a visual to help with that. So you'll see that the standalone sites receive directly from the clients the blood samples, and they are processed on site. And then in the hub and spoke networks, hub sites will receive blood samples from nearby spokes that otherwise alone wouldn't have had the throughput to be able to handle the placement of a platform. But when you combine them to form a network, the throughput is possible. It's reached. As well, we opened up to receive tests from multiple entry points in addition to PMTCT and ANC services. We are also accepting tests from maternity, pediatric, inpatient wards, vaccination clinics, and outpatient clinics. So when we started our project, we planned for a pre- and post-intervention evaluation to be able to compare POC with conventional EID across several key service delivery indicators. For our pre-intervention baseline data, we collected testing data for HIV-exposed infants who had been tested with conventional EID. We extracted data from registers and ultimately were able to collect data for just over 2,800 kids in 96 sites in 8 project countries. And I should mention that one of those project countries was actually not included in this analysis because they weren't implementing at the time. So we are, in fact, analyzing data for 8 countries. For the post-intervention data, we're presenting data here that was collected between December 1st, 2016 and December 31st, 2017, again from 8 project countries. The data were collected once the platforms were in place, and we collected data using a newly introduced POC test request form that was project-specific, and that form was actually used in 7 of the 8 countries included in the analysis. In the last country that didn't use this form, we simply extracted data from existing resources at the facility. So here in the analysis, we have just over 19,000 tests for just over 18,000 kids from 339 sites. And I should mention that since then, we've more than doubled the number of kids and tests. So here are our results. Our data show that POC did significantly better across all of our key indicators as compared to conventional EID. 5 times more results were returned to the caregivers within 30 days when the kid was tested with POC, and that 30 days turnaround time is as recommended by the WHO. The median time turnaround time to results to caregiver was 0 days with POC as compared to 55 days with conventional EID. 90% of HIV-infected infants were initiated on treatment with POC, and when you look at that total turnaround time between blood sample collection and initiation on treatment for HIV-infected children, you see a considerable difference from 49 days to 0 days. So this means here that HIV-infected infants are being started on treatment on the same day that they are tested. We also wanted to consider the effect of the test versus the spoke site because it's such an important aspect of our approach. And here are some of our results. So despite a statistically significant difference in most of our outcomes, clinically, we do not believe that there is a difference. And what's particularly encouraging and important is that if you look at the percent of HIV-infected infants started on treatment within 60 days, which is that peak mortality rate, peak mortality, there's no statistical difference or clinical difference. As well, we see that POC is equally beneficial across alternative entry points, including pediatric and outpatient wards. These results show that these entry points actually had a higher positivity rate than the PMTCT clinic. Children presenting at these entry points are often at advanced stage of illness, and as a result, time is of the essence. Children don't usually stay long in pediatric wards because they'll either be discharged or unfortunately die before results are received through conventional testing. This makes urgent treatment essential. Okay, cost per test result return. When doing our cost per test analysis, we actually thought that the cost per test result returned was actually a closer measure of the true value of the diagnostic. Why? Well, because if the test result is not returned to the caregiver, a clinical decision cannot be made, and so we can consider that wasted resources, wasted money. The cost per test result received was calculated using the Global Fund's total cost of ownership, or TCO, estimates for both the POC and conventional EID. So if you look at the first row, total cost of ownership, we see the average TCO estimates for both POC products that we used in this project, as well as the conventional EID products. As the TCO is dependent on instrument throughput, for POC EID, we also calculated the TCO based on our current throughput, which is up to 3 tests per day, as well as by optimal throughput, which is calculated by the Global Fund, and that's about 70% of platform capacity. So if you look in the second and third rows, we see the average TCO for both conventional and POC that were then divided by the average percent of results returned for each respective testing modality. If tests are returned within 30 days, POC is considerably more cost-effective than conventional, and most test results are returned within 30 days with POC. If tests are returned within 3 months, which most tests are with both modalities, then costs start to even out, but POC remains more cost-effective. So what does this mean? Well, we believe that this is actually the first multi-country evaluation using routine POC testing data collected within MOH structures. This is real-world evidence that shows that POC can significantly improve EID outcomes when compared to conventional EID. The hub and spoke model has, we believe, extended successfully access to testing without compromising the quality of care, and our calculations do show that POC is cost effective. So by bringing the test closer to the mother-baby pairs, POC is making it easier for caregivers and clinicians to get their test results back sooner, make clinical decisions faster, and when necessary, initiate on treatment earlier. Thank you.
Thank you, Flavia. Great job keeping on time. And now we'd like to welcome Auxilia Muchedzi from Zimbabwe. Auxilia is a public health specialist with over 12 years of HIV programming experience in Zimbabwe. She's currently employed by FHI 360 as a senior technical advisor. She has HIV programming experience from both the public health and the NGO sector, and we look forward to hearing from you.
Thank you very much for the kind introductions. And a good afternoon to you all. I would also like to thank the International AIDS Conference for giving me this opportunity to make this presentation on improving technical efficiencies, reaching the first 90 through community index and sexual network HIV testing in Zimbabwe. This is the outline of my presentation. I'll give you a brief background on the Zimbabwe HIV context and the progress that it has made towards the 1990 targets, the description of the Zimbabwe HIV care and treatment project, which is being implemented by FHI 360 in Zimbabwe, and the testing approaches that we are using, the lessons learned, and the conclusion. Here is the HIV country context for Zimbabwe. Zimbabwe is in sub-Saharan Africa with a population of 13 million and an HIV prevalence of 14% in the adult population. A total of 1.3 people in Zimbabwe are living with HIV. Zimbabwe has made a huge progress towards the UN AIDS 1990 targets, as can be seen in this figure. The last 2 90s, Zimbabwe has done extremely well. However, there are still challenges within the first 90, with only 74% of people knowing their HIV status, and also with men lagging behind in knowing their HIV status. This therefore means that Zimbabwe has to come up with innovative approaches for it to be able to reach the last mile. FHI 360 in Zimbabwe is implementing the HIV care and treatment project, which is responding with community index HIV and sexual network testing to be able to close the gap in the first 90. The FHI 360 program is being implemented in 8 rural districts, and the goal of this program is to increase access and availability of comprehensive HIV care and treatment services through community-based interventions, and the program complements the Ministry of Health efforts towards the 1990 targets and also towards ending AIDS by 2030. The community index testing approach is an HIV testing approach that is being provided to sexual partners and children of index cases that are identified to be living with HIV at the health facility level. This is done by trained nurses at community levels. The FHI 360 is a strengthened community health system of trained nurses and community-based cadres who are expert patients that are identified and are resident in the communities where this program is being implemented. The FHI 360 team works very closely with the health facilities and also with the communities to implement this approach. The process starts with identification of index cases at the health facility from various service delivery points at the health facility level in collaboration with the health facility staff, or index cases can also be identified from other community health interventions that are being implemented in Zimbabwe. The FHI 360 supported community cadre or expert patients obtains consent from the index cases, makes appointments, and prepares the contacts for household visit by the nurse tester. The nurse tester then visits to provide HIV testing, and all people that are identified to be living with HIV are linked for ART initiation at the nearest health facility or through community ART initiation by working very closely with the health facility. In addition to HIV testing and counseling, the nurse testers also provide integrated health symptom screening for non-communicable diseases, particularly for hypertension, diabetes mellitus, and malnutrition. They also provide health education on HIV and health-related topics, plus adherence counseling, and then also referrals for clients that are symptomatic for NCDs. This slide that you are looking at shows you a successful sexual network testing, the case of Tinotenda. The slide will try and explain the process that we do when we are conducting sexual network testing. The nurses on the program are trained to be able to explore sexual network. They don't end just by testing the sexual partner. This is the case of Tinotenda. a case that was identified at a health facility to be living with HIV, and 2 of her sexual partners and child were tested for HIV and all turned out to be living with HIV. And the sexual network was then explored as outlined in this diagram. This is a summary of Chinotenda's sexual network testing. A total of 7 HIV-positive people were identified on this sexual network, and all 7 were initiated on ART. This process took about 4 weeks, and a total of about 230 kilometers were covered by the nurse tester using motorcycles. The following slides will show you the achievements that have been made on the program, and this slide shows you program data for October 2016 to September of 2017, showing that close to 15,000 index cases were identified from 330 health facilities, and a total of 2,100 people were provided with HIV testing services. Of these, 8,367 were identified to be living with HIV, giving a yield of 38%, and 69% of them were initiated on ART at the time that this abstract was submitted. However, by June of 2018, the initiation rate was up to 89%. The approach or the program is reaching mainly the people in the 25 to 49 age band, and the FHI 360 program is also reaching men. Of all the people that were tested on this program, 48% of them are males, and 93% of the males that were tested are adult men that are above 15 years of age, and 34% of them were identified to be living with HIV. Coming on to efficiency of community index HIV testing with sexual network testing. After the introduction of sexual network testing on the program, we have noted an increase in the number of HIV-positive tests or persons identified, whilst the number of HIV persons tested was reduced. And one HIV person was identified to be living with HIV for every 1.8 index cases that were followed up. And coming on to yield, also with sexual network testing, we have noted that the program is achieving high yields with an average yield of 38% with sexual network testing, and with a yield in sexual partners of 44%. In conclusion, the community HIV index testing coupled with sexual network testing is efficient in the terms that it increases the number of HIV-positive persons that are identified to be living with HIV. It achieves high and sustained yields, and is also reaching key subpopulations, including men who would not ordinarily access HIV testing using traditional HIV testing methodologies. As next steps, Zimbabwe and FHI 360 would like to expand this approach to the districts where it's not happening, and also to integrate HIV self-testing to improve the efficiencies of HIV testing in Zimbabwe, to provide PrEP to the HIV-negative people that are identified on the program, particularly the high-risk populations, to scale up ART initiation, and also to conduct some cost analysis to understand the cost per HIV-positive person identified using this approach. I would like to acknowledge the people that are on this slide, including the ZX City project staff and project beneficiaries. I thank you.
Thank you, Auxilia, for that interesting presentation. Our next presenter is Andrew Phillips. He's an epidemiologist who has worked extensively on HIV observational cohorts, randomized trials, and on individual-based models of HIV transmission, progression, and effect of antiretroviral therapy.
Thank you. I hadn't realised that I had to do it myself. Good afternoon. So the background to this is that HIV testing is key to global ART-based HIV prevention efforts. It's widely accepted that testing in pregnant women for diagnosis of symptoms where there's a suspicion of HIV, testing in sex workers, and in men coming forward for circumcision is beneficial and cost-effective. And we refer to this in this presentation as core testing. However, as prevalence of undiagnosed HIV declines, as we've heard, it's unclear whether additional testing beyond this core testing will always be cost-effective. So the cost-effectiveness of an intervention is assessed by calculating the incremental cost-effectiveness ratio, or the incremental cost per DALY averted, over a suitably long time horizon for prevention interventions. But this metric is not something that can be measured by testing programs. So to guide their testing programs, countries require appropriate metrics that can be measured, and the cost of testing per new HIV diagnosis achieved by programs is a potentially useful metric. So the objective of this then is to assess whether the cost of testing per new HIV diagnosis is a suitable metric for measuring the cost effectiveness of ongoing testing programs in the context of HIV epidemics in low-income settings in sub-Saharan Africa. So to assess, and then secondly, to assess the maximum, if it is, then to assess the maximum cost of testing per new diagnosis for a testing program should be achieving to be cost-effective. And lastly, to consider the implications for monitoring of programs. So the methods here, very briefly, are that we use an individual-based simulation model, which has been used fairly extensively for questions in this region. It's a model of sexual activity, HIV testing, HIV transmission progression, and the effect of ART. And using this individual-based model, we generate several, in fact, 1,000 setting scenarios which resemble those seen in Southern Africa. So just to give you an example now of what the situation, these setting scenarios look like at baseline in 2018, I'm only just going to show you three examples. Of HIV-positive people, the proportion diagnosed, you can see 73% on median over these 1,000, 73% in men and 89% in women, but you can see the range across these setting scenarios that we're considering. Similarly, for the proportion of diagnosed people who are on ART, and lastly, for the proportion of people on ART who have viral suppression. Again, there's quite a range across. And on the right-hand side, you can see some examples of data from the region. And I could have showed you about 5 slides of this, but I thought that you probably would, that there wouldn't be time. So what about the testing policies that we looked at then? So for each setting scenario, we continue the simulation to project forward 50 years from the baseline in 2018 under 2 policies. The first one is just to have core testing only. The core testing that I mentioned is the only testing that's happening. And the alternative is to have core testing plus additional testing. So now the additional testing is determined by sampling at random from the rate of testing and the relative probability of an HIV-positive person being tested compared with an HIV-negative person being tested, which within a model where you know true HIV status you can do. So this was done in order to generate a range of different testing volumes and proportions of additional testing resulting in new HIV diagnosis. And we consider amongst these 1,000, we consider additional testing only for men, only for women, or for both genders. So then we also considered 16 different unit costs of HIV tests for each of these 1,000 setting scenarios, ranging from $1 as a unit test per HIV test performed up to $36 per unit test performed. And so that gave us a total of 16,000 setting scenario combinations with unit tests, different unit tests. So we have a sort of data set, simulated data set of 16,000 rows. And for each of those, we then calculated the cost of testing per new HIV diagnosis resulting from the additional testing. And that was the ratio then between the cumulative cost of the additional testing divided by the number of new diagnoses. And that was averaged over the first 5 years of the simulation, 18 to 23, to get a stable, reasonably stable estimate. And then we also calculated what we really want to know, the cost per DALY averted of the core versus the additional testing over this 50-year time horizon. Because the model is calculating, is simulating the DALYs incurred. We take a healthcare perspective for this analysis, use a discount rate of 3% per annum, and for the base results, we consider a cost-effectiveness threshold of $500 per DALY averted. So what's the effect then of this additional testing? Just a couple of sort of intermediate markers of what the impact is, and again, there's a wide range. So of HIV-positive people, on average over these first 5 years, we've increased by 7% the proportion of women diagnosed, but with quite a wide range, and more so the proportion of men diagnosed because they were starting from a lower point, but also a very wide range in what the effect the additional testing has had. And then the cost of testing per new diagnosis, considering the whole 16,000 now, you can see we've got a very wide range from $25 per new diagnosis found as the total cost of testing up to over 7,000. So to finally show you the main results, which is to show you the relationship between the thing you can measure, or at least we can discuss how easy it is to measure, but the thing that at least you've got a chance of being able to measure, the cost of testing for new HIV diagnosis, and the thing that you really want to know if you know to understand the cost effectiveness of your intervention, which is the ISA, the median cost per DALY averted. And you can see that, as we'd hypothesised, there is actually a very strong relationship between the two, suggesting that you can tell quite a lot about the ongoing cost per DALY from the cost of testing, cost per DALY averted from the cost per new HIV diagnosis. And if you're using a cost-effectiveness threshold, I mean, a country can use whatever threshold they want, of course, and whatever they think is appropriate. But if we're using a $500 per DALY averted threshold, then that's round about $300 is the kind of threshold beyond which the cost of testing for new HIV diagnosis should be on average, according to this, to be cost effective. And to look at this in this is a very similar presentation of the same result, but we're now just looking at if we accept that we're having a $500 per DALY averted cost effectiveness threshold, then this is the percentage of setting scenarios in which the additional testing was cost effective, according to the same x-axis, the cost of testing for HIV diagnosis. And it's essentially telling the same thing. When it's very, very low cost of testing per diagnosis, then there's almost an 80% of setting scenarios it was cost effective, going down to 0. And if you fit a curve through this and see where it crosses here, then it crosses here at $315. So that's an overall result. But what if you break this down into various subgroups? And the result that I have to admit I was surprised by is that the result is relatively stable according to that. So if you look at the lowest tertile of undiagnosed prevalence, so if the undiagnosed prevalence is right down here versus higher levels of undiagnosed HIV prevalence, there's not a lot of difference in the value. And similarly with HIV incidence and the percent of HIV diagnosed people with viral load less than 1,000, which I take as a kind of general measure of how good the program is. On the other hand, though, if you then add this at the top and you break down and say, what does this look like if you look stratified by men and women, then it's quite dramatic difference then in the additional testing in men becomes the threshold is nearly $600 per new diagnosis that it's worth paying in order to remain cost effective. But in women there was no even at the very lowest cost per new diagnosis, there was no level at which it was cost effective on average to be doing this additional testing beyond this core testing, which already includes testing in pregnant women, women with symptoms, and sex workers. So just a couple of comments. The implementation of our results requires that programs can estimate, obviously, the full cost of testing and also the number of new HIV diagnoses in a given period. And, of course, programs will need to account for the fact that some people incorrectly report that they have previously been diagnosed. So there is an issue about how to actually count this, because we are assuming that these are genuinely new diagnoses. So how to count the number which are genuinely new diagnoses is an issue which I realise needs addressing and coming up with solutions. And secondly, we calculated the cost of testing for new diagnoses over the first 5-year period, as you saw. But this could change over the subsequent period, and it did change to some extent, although not a great deal. So I'm assuming that this additional testing goes on for the whole 50 years. If we'd been talking about additional testing programs which only last 5 years or only last 10 years and then stop, then the cost effectiveness could be higher. So to conclude, the cost of testing for new HIV diagnosis is a suitable metric for measuring the ongoing cost effectiveness of additional testing programs beyond core testing in the context of HIV epidemics in low-income settings in sub-Saharan Africa. Considering a cost effectiveness threshold of $500 per daily averted, such additional testing programs in men are likely to be cost effective so long as the cost of testing for new diagnosis is below about $500. On average, additional testing programs in women beyond the core testing are unlikely to be cost effective. And that really effectively means that if they're not achieving, if they're not cost effective, it effectively means that the money that is being spent on those programs could gain more health elsewhere in the healthcare system or for other HIV interventions for women and men. So thank you for your attention.
Thank you so much, Andrew. That was really exciting. Our next presenter is Catherine Dovell. She's going to present on facility-based HIV self-testing for outpatients. Catherine Dovell currently works at the Department of Medicine at the Division of Infectious Diseases at the University of California, Los Angeles, and Partners in Hope in Malawi. Catherine does research in medical anthropology, international and humanitarian medicine, and public health. Thank you, Catherine.
Great. Good afternoon. On behalf of my co-authors, I'm pleased to present to you results from our study examining facility-based self-testing among outpatients in Malawi. HIV testing strategies need to be expanded, particularly among youth and men. We continue hearing about this throughout the conference. Self-testing offers a promising strategy. However, to date, most self-testing strategies have been conducted in community-based settings outside the existing health system. And we asked the question in Malawi, what would it look like if we integrated self-testing into an existing health system within the facility? We hypothesized that facility-based self-testing would be beneficial because it may address many of the remaining concerns or questions with self-testing, such as the scalability, quality assurance, and linkage to care. We also hypothesized that facility-based self-testing may be particularly useful for outpatients, where we have a high volume of clients coming through who we still struggle to really reach with self-testing or with testing, even though they're in the facility setting. To answer these questions, we conducted a non-blinded control randomized trial in Malawi with outpatients. Our primary outcome was proportion of outpatients tested for HIV using an intention to treat analyses. And our secondary outcomes include HIV positivity rate among those tested, linkage to ART among those who are new positives, acceptability of the strategy, and any presence of adverse events such as coercion for clients who were in fact exposed to a testing strategy. The study was conducted in 15 high-burden, high-volume sites, specifically the outpatient departments, and we randomized 5 facilities per arm using block randomization, and we blocked based on region and facility type, meaning either district hospital, hospital, or health center, in order to have similarities across arms. Our eligibility criteria, adults 15 years of age or older who were actively seeking outpatient services on the day of enrollment. And in order to evaluate the impact of this strategy, we conducted exit surveys with a subsample of outpatients. And the reason we did a subsample was the huge logistical challenge about doing surveys with a large volume of people in a busy clinic where we have limited privacy. Medical chart reviews were also completed for the same clients who completed exit surveys in order to assess ART initiation 3 months after enrollment into the study. We included 3 arms in this study. First arm is standard provider-initiated testing and counseling, or PITC. For standard of care, what this means is that a provider may refer clients to HIV testing while they're being seen for routine outpatient services. And that can range anywhere from a broken arm, malaria, or general illness. An important point to note for the Malawian setting is this means that clients are referred to an HIV department, most likely. And that means that they must leave the outpatient department, go to another building, and wait in a separate line or queue in order to receive HIV services. Second arm is optimized PITC, and this is where we offered HIV testing before clients received general outpatient services. This allowed us to provide testing right there in the outpatient department, removing the need for clients to go to another building and wait in another line. Finally, we had facility-based self-testing. Again, we offered this before clients received outpatient services. We used OraQuick HIV self-test kits. And I'll tell you a little bit more about the facility-based self-test strategy now. So in a high-volume, busy outpatient clinic, we have a unique opportunity to have a captive audience. And Malawi clients spend over 3 hours waiting for health services, and most of the time is spent in busy, crowded waiting areas like you see here. Clients are often reluctant to leave the waiting space because of fear that they'll lose their line in the queue. We decided to take advantage of this waiting time by offering self-testing. One study staff member was dedicated to the demonstration, distribution, and assisting with the use of self-test kits while clients waited in the queue. Importantly, the majority of activities were conducted in a group setting, like you see here. This allowed one healthcare worker to test a large number of people in a short amount of time, something that is unique as compared to traditional testing strategies, where we require one-on-one interactions. Private rooms and booths were provided for test interpretation, and clients were highly discouraged from interpreting results or looking at their tests while in the waiting space. We also provided multiple reasons for clients to opt out of self-testing and discouraged testing among those who already had a positive status. Finally, we did provide post-counseling as well as immediate same-day ART initiation for those who chose to disclose their HIV status. However, they were not required to do so. We had over 13,000 adults attend outpatient clinics within this study period, and about 45% of those completed an exit survey. So our results come from this 5,885 outpatients. We see that the key demographics, we see similarities across arms, and we see about 39% of all respondents are male with an average age of 32 years. Now for our findings. Here, I'm going to show you a variety of slides looking at differences between the different arms. Here, the blue represents the standard PITC, red is optimized PITC, and the green is our facility-based self-testing. And I broke this down. Always you'll see the total on, I guess, your left, and then broken down by different demographic characteristics. We find that self-testing dramatically increases the proportion of outpatients tested. Again, we use an intention to treat analyses, which means we present the proportion of all outpatients tested, including and not taking out those who either were already positive or recently tested previously. And I think one thing important to point out here is we see greater benefits for the youth, where 11% of youth were tested with a standard PITC compared to 50% of youth using facility-based self-testing. And what you'll see moving forward is that because of the dramatic increases in testing, this also influences the absolute number of new positives identified and people initiating ART. Here we see similar positivity rates or yields across the different arms. We're seeing about 2.7%. And we do see higher positivity rates among men, speaking to the unmet need among this population. But as I hinted to earlier, despite similar positivity rates, we do see a higher number of new positives identified due to self-testing, where we have 27 new positives identified compared to 6 in our standard PITC. We also assessed ART initiation among new positives within 3 months of testing. So there are too few new positives to make concrete conclusions about ART initiation. We have 41 new positives in total. However, the trends are promising. We see facility-based self-testing has about a 70% linkage rate, which is higher than a lot of other self-test studies that are done in communities, where we see about 25 to 35% linkage. And I think we just need additional research on this to be able to explore exactly what is happening with linkage if we have a larger number of new positives. While we know that facility-based self-testing works, we're getting people tested, we're getting them into care, questions come up around acceptability. And this is important, particularly given the group dynamics of the intervention's design. We find that facility-based self-testing was, in fact, acceptable. When asked if a client would use the same testing strategy again, clients who were exposed to the strategy almost unanimously agreed. And you can see differences here. Again, the greatest benefit is for the youth, where 80% of youth said that they would test using standard PITC again, whereas 98% said that they would test using facility-based self-testing. So again, we're reaching this currently missed population. Finally, coercion is a concern with something like this, where we're doing facility-based group-oriented testing. We asked all clients who were exposed to a testing strategy if they were coerced or pressured to test, and for those who tested, if they were coerced or pressured to share their test results with anyone, whether that be a healthcare provider, a neighbor, or a fellow outpatient client sitting on the queue. And what we found is we had no reports of coercion among the self-test arms, with low levels of coercion reported amongst the standard and optimized PITC arms. In conclusion, we find that facility-based self-testing dramatically increases the proportion of outpatients tested and results in a higher number of new positives identified and also initiated onto ART. Although, like I said, further research is needed for ART initiation given our small sample size of new positives. This strategy is acceptable, it's not coercive, and it should be explored for other high-volume, high-burden outpatient settings throughout the region. I think I want to go ahead and highlight here that we do have additional information from the study presented throughout the conference. We do see that the intervention is cost-effective, and you can find that poster, I believe, tomorrow. And we also have additional information on who is opting out of this strategy and why. Just quickly, we find that concerns around privacy is not an issue. It is not a reason people are opting out. In fact, people opt out of facility-based self-testing for the same reason they opt out of most testing strategies, which is that they don't think that they're at risk and they're not ready to test. So we still have additional work around that, but the intervention itself was acceptable. With that, my colleagues and I would like to acknowledge funding from USAID and PEPFAR and continued support from UCLA, and also acknowledge the endless work being done in Malawi on the ground from Partners in Hope and the facilities in which we work. We're very grateful for all of the support.
Great, thank you so much for these fantastic presentations. If there are, whoever has a question, please come to the mic. I see Chiweluo. Anyone else, if you can line up, then we can get them in a row. What I would propose is that we take a question for each of the speakers, or a number of questions, and then we can go presenter by presenter. So Chiweluo, please introduce yourself to the audience.
Chiweluo from UNICEF. Thank you for the wonderful panel. Honestly, very interesting presentations. But I had a question for Cameroon, I think it was, that looked at performance-based financing, our colleague from the World Bank. One of the things I do know in Cameroon that's hindering access to PMTCT services is user fees. So I'm just wondering how, within your evaluation, you factored that in. I was actually quite surprised at the impact on the other services within the facility of the performance-based financing. And I'm just wondering, first of all, where did you peg how did you decide on how much to give to the facility, and whether the user fees are playing into the impact for the other services that are being provided? Because I think we need to crack that to get things going in Cameroon. I wanted to also just ask a question to my colleague from ECPAF. Your study, your evaluation is amazing, but one of the things I picked up was your yield was much higher in the outpatient clinics and also in the inpatients. Now, I think we need to look at that critically, especially in countries where we still have a lot of children turning up sick in the clinics, because this could be a child survival strategy, because we can't wait when a child is sick, because that might be an AIDS-defining illness.
Thank you, Chewe. You were there first, so I'm going to go over to that side of the room.
Okay.
Please introduce yourself.
Yeah, my name is Rabia. I'm from Kirby Institute. I have two questions for Andrew. Actually, do you think that actually the metric for the new infected diagnosis is good for scaling up of universal test and treat? And the second question is, do you think that actually this metric will be underestimated cost effectiveness for the setting in the country where it's low prevalence and big population like Indonesia, for example? Yeah, thank you.
Good afternoon. Thank you so much for a great panel and all really, really, truly relevant presentations to refine and improve our programs. Ocelia, I had a couple of questions for you. Congratulations for sort of great yield and success in implementing the 2 modalities in Zimbabwe. No doubt you'll help the country improve their achievements in the first 90s. A couple of questions. Since you were describing the facility being your sort of starting point, so facility healthcare workers tell you which the index case patients are. Can you tell us sort of what proportion of newly diagnosed patients at the facility actually do need the community-based support for follow-up? Because I imagine that there is a proportion of patients where the partner elicitation notification can occur through the facility and the partners are happy to come in just as a result of an invitation from the client or the healthcare worker at the facility, whereas a proportion X may need the more intense community-based support. And a second question, in the clients you saw at the community level through either of these 2 modalities, how many or what proportion may already have known that they were HIV positive but possibly did not disclose to their partner, and or did you find some, what proportion was of these may have already been on ART, or did you find some lost to follow up? Thank you.
Thank you so much. Who has a question for Catherine? Perfect. Please introduce yourself.
Thank you very much. Good afternoon. My name is Noktula. I come from Botswana. My question to Catherine, I would like to know whether or not you use the HIV self-testing as a diagnostic test or as a screening test. That is to say, those who HIV self-tested, if they get positive, do you link them to treatment straight away, or you do a confirmatory diagnostic test first? Thank you very much.
Thank you so much. We're going to take a break and we're going to answer those. And we do still have half an hour, so probably we'll get to yours. Shall we start at the end of the table? Auxilia?
Oh, okay. Thank you very much for the questions that I got. I will respond to the one on firstly on the one on facility versus community index testing. I'm not sure I got it right, but I think she wanted to understand the proportions that would want to come back to the health facility and the proportion that would prefer to be tested in the community. I may not have the actual proportions as we speak, but we're looking at about probably 35%, 65 of them wanting to be followed up in the community. However, as a program working very closely with our health facility partner, we've come up with a standard operating procedure and a flow chart that actually at the point that the client is identified to be living with HIV, they actually give the client those 2 options, whether they want to bring their partners to the health facility or they want to be followed up in the community. It is only then, if the client wants to be followed in the community, that they register them in our index case register. And if a client then says that they want to bring their contacts to the health facility and they don't bring them within 72 hours, the list of the clients that have tested positive would then be given to the community partner who is FHI 360 to follow up in the community. And then the second one on retesters, Yes, we have noted as a program that there are some people, particularly that we are working in the communities, there are people who would want to confirm or to have a retest for several reasons whilst they already know their HIV status. But we have systems in place that ensure that the data that we report, we exclude all non-HIV positives. We have a standard operating procedure starting with our community cadres and also with the nurses when they do their pre-test counseling and post-test counseling. They have questions that they ask the client to try and ascertain if the client does not already know their status. And once the client is identified in the community to be living with HIV, our nurses go to the health facility and verify with the health facilities, particularly in sites where we have an electronic patient monitoring system. They check with the EPMS to see whether that client is not on ART. And for clients that are identified or to be living with HIV at that point, they are excluded in the data. And the data that I presented here actually excludes those non-positives. And across the program, the retesters come to about 3.4%. And in our districts, they are variable in various proportions, ranging from about 1% to about 4.5%.
Thank you, Celia.
Okay, so the question about result-based financing in Cameroon. Thank you very much for asking the question about the user fee, because it allows me to mention a result that I omitted from my presentation in the interest of time. When we looked at the household survey, we find that actually the user fees, both formal and informal, were reduced for the household that were going to the facilities receiving results-based financing. And that was only in that group that was receiving the full performance-based financing. So given that with performance-based financing comes management autonomy, it seems that indeed it was one of the strategies that the facilities were using to attract more patients was to reduce the user fees, including the informal user fees. No, the second part of the question was, how did you decide how much to give for which kind of services, etc.? And for this, we had a budget envelope, and then we decided with the people in the ministries, in the facilities, looking at how much time was taken for each services, etc. I will point that you can also use this. You can use this price setting to give specific incentives. In another study that we did with performance-based financing in Rwanda related to HIV testing, we were paying $1 for each HIV test, but $5 for joint testing by couples. So $5 is more than 2 times 1. So it was clearly incentivizing joint testing by couples. Thank you.
I feel like Chewe's question was actually more of a recommendation than a question. And all I can say is that we were, I think, equally surprised to see the high positivity rate in the inpatient and outpatient wards. And we are actually sitting on loads of data, and this is just scratching the surface. So we are definitely planning to investigate a little bit further into what this means for the services that we provide. And we'll release our results as they come up.
So thanks for the questions. I had a question, if I understood it correctly, about whether this would be useful in scaling up test and treat. And so our analyses, as you heard, I feel certainly hold for low-income settings in Southern Africa. And within the model, we are assuming we are assuming that there's a policy of immediate ART initiation regardless of CD4 count. We're not assuming that no one gets lost after the diagnosis and that everyone starts, but we're assuming that is the policy. And so effectively, yes, is the answer to that question. I do think it could be used for that. And potentially elsewhere in sub-Saharan Africa, I think, but outside that, then I wouldn't be comfortable because the model's really not calibrated to those areas. In terms of the question about is there an underestimate in a situation with low prevalence, is that I don't think so. I mean, that is the kind of most important result is that this metric seems to be suitable when there's a very low undiagnosed prevalence and when there's a much higher undiagnosed prevalence. It's harder to, when there's a very low undiagnosed prevalence, it's harder to achieve the target, but nevertheless the target seems to be the same.
Great, thanks. The question was regarding if self-testing was used for diagnostic or screening purposes. So we know that the specificity and sensitivity of self-testing is very high. However, it is dependent on how well the user actually uses the self-test kit. Because of this, self-testing for the study and in Malawi is as a screening tool. So we do complete then confirmatory testing before someone can initiate ART.
So we'll have the next round of questions. We'll take 5 questions and then we'll ask the presenters to respond again. We can start from the far end there.
Yes, this is I'm Mike St. Louis from the US CDC and from PEPFAR. And for Andrew, first a comment and then a question. The comment is that it's fascinating that you found this cost-effectiveness value for this particular metric. I think that at the US CDC and within PEPFAR, we've actually been trying to move toward precisely that metric, the cost per new positive detected, as the key metric to drive our view of the efficiency of HIV case finding. And it's useful also to appreciate that it can be used not only across the board for the whole population, but within a subsegment of the population. For example, if you're looking for men of a certain age, you can compare different cost of HIV positive cases detected, and that's a very, very important tool to figure out how for resource allocation. My question gets back to the really interesting sexual network testing from Zimbabwe that shows this very high yield of certain types of certain categories of new positive tests, the index tests. And I wondered if you've thought about or have already factored in the potential for that additional case finding that can come from the sexual partner testing, such as was demonstrated in Zimbabwe. Has that factored into your modeling of the cost effectiveness at all?
The next question, please.
Good afternoon. My name is Catherine Guerra. I'm with the Clinton Health Access Initiative. And my question is to Catherine. And if you could speak a bit to the infrastructure element of this model of HIV self-testing in the facility. I noted that you mentioned that there was a spot for privacy for interpretation of results. And if you could just speak a bit to whether or not that was already available within the facility or something that you had to make available as part of the study, and kind of what those requirements were, how many rooms you had to have versus tests done, or load of the outpatient setting, and to what extent you think that would be a barrier as we think about scalability of self-testing within facility settings. Thank you.
From the far end.
All right, thank you so much. Great presentations from all of you. Thank you so much. My name is Dominic. I work with Lighthouse at Central Hospital in Lilongwe, Malawi. I have a question to Auxilia. Great program that you are implementing. We are implementing a similar program back in Lilongwe. And what we have observed over time is the yield is kind of like dropping. I'm not too sure whether you've been able to observe the same, and if it is yes, what you think would be the reasons. Thank you.
Thank you so much. My name is Lawrence Mwenge. But Kwame, you said you need 5 questions. Is it 5 individuals or 1 question for 1 individual? 1?
Let's go ahead.
Yeah, so I think let me be efficient. My question goes to Andrew. Andrew, I'm very fascinated by your work, and especially that is dealing with Southern Africa, which is among, most of them are low-income countries, because, you know, sometimes I'm not very up with the WHO threshold of, you know, per capita income. So when we have such things, I think we are moving towards something. But my question is around my confusion. You said your threshold, benchmark threshold, which was a 500 per dairy abated, but you compared with the per cost, new tester cost. So I wonder, just to be clear on, because I feel like you are comparing apples with oranges here. You mentioned the area that dairies is a wide dimension metrics, but this metrics is only based on the HIV testing, the per tester. So can you just talk about how you are comparing the cost per dairy versus the new matrix that we are trying to propose, which is per tester cost? Sure. Then Catherine, the question that I have with you is, we are talking about self-testing in terms of trying to reach the 90-90 target, or if we have the 95-95, 100-100. But the issue that we have especially is working well with men. Men usually they don't come to facilities, are in the community. So can you comment compared to I like community-based delivery of HIV self-testing compared to the few who come to the clinic, usually women, which some studies are finding not to be, any difference when they compare. In your proposal for the facility-based, and we come to the issues of efficiency and the investment. Where do we put money on? Is it what you are proposing, or is it what other people are proposing? Thank you.
Thank you. I think we'll ask the presenters to respond. We can start from Catherine.
Thank you very much from my colleague in Lilongwe. In Zimbabwe, we have not yet started to see any decrease in the yields, and maybe it's because from the data that I presented here, if you look at our first 90 is currently at about 74% using the Zimfia data. So probably that means that we still have a number of people out there that are living with HIV. I don't know where your first 90 is Lilongwe, but as of now, I cannot comment whether our yields are decreasing. They are not decreasing, but maybe going forward when we close the gap. Thank you.
Yeah, just to add my own question as well, Auxilia, because we know that index testing definitely has a high yield, but it does leave out a lot of undiagnosed people with HIV when you compare it to other models like door-to-door HIV testing. Andrew?
So in answer to the first question about the relationship, if I understood it correctly, with the example of the Zimbabwe sexual network testing, I think this is an example of where there's a way of testing which potentially has a very high yield, and therefore but it's very difficult to intuitively know what cost you should be putting in per positive identified. So that was part of the purpose of having that kind of range of up to $36 per unit test, but potentially it should go higher than that. So I think that in order to be able to test to monitor the cost effectiveness of programs as diverse as that one and other more less specific programs, it does seem to me that it would perform quite well as a metric. If I understood the question about I think I was asked about to explain more about the relationship, how I kind of got to how the model translates between testing and dairies averted. If I understood the question correctly, and basically we try to mimic all the processes we think are happening in terms of people getting put onto treatment and therefore being less infectious and therefore being less likely to infect other people, being less likely to get age-defining conditions and die. So basically playing out over the next 50 years why less dairies occur. Not the kind of thing that a program can do by itself. So that's, I don't know if that answers it at all, but the model is the kind of engine for getting between the X and the Y's.
Thanks. The first question was around infrastructure for privacy. It's a great question. Ideally, we would have had a private room, multiple private rooms where people could interpret tests. But as we all know, in busy, crowded health facilities, that very rarely is an option. So for this study, we built small, collapsible booths where people could go and interpret their test kits. And it was a one-person booth, standing, that fit within, for the most part, fit within the outpatient department. And then we tried to shift the flow of clients so that clients could wait in the queue or wait in the open space. And once, right before it was their turn to go into the provider, they could then go to this booth and interpret their results so that we didn't have a crowd of people waiting near this makeshift private space. The second question was around men, and I think it's a great question. I think we're all certainly concerned about how to best engage men. My argument here would be, despite the fact that we say men don't come to the facility, we actually had 39% of all participants were men. So we are having, in fact, men come. I think a remaining question is, how frequently are men coming, and are most men within a community coming to the facility? Or are we seeing a certain proportion repeat coming to facilities? And we're looking to explore that and really assess at a community level how frequently are men coming. But I think we learned from Andrew's study and others that really, if we have something like the ANC program where we have a universal catchment point for men or women, where every several years they come in and are tested, that would be enough. So I think the real question is, how frequently are men coming to the facility? And I don't think we quite know that yet.
Thank you so much. So we have time for the last 4 questions, I think, so that's fantastic. So we're going to start on that side of the room. We'll get to you next.
Good afternoon. I'm Cecilia K. Raba from Liberia, representing people, network people living with HIV and AIDS in Liberia. I'm HIV positive. My question has to do with self-testing. It is good, but if someone is tested positive, he or she decided to not disclose her status, go around spreading it in the community, what measure will be taken to avoid that situation?
And who would you like to answer
the
your
last
question?
Presenter.
Okay.
Yeah, I'm Stanley Way, from the US CDC office working in Mozambique. My question is for Andrew. I guess I have a comment and a question. The comment is about your sort of striking finding that additional testing is not cost-effective for women. And when I think about applying that to our Mozambican context, it doesn't fit so well, in the sense that our biggest additional programs that involve women include index case testing or sexual network testing, in which intrinsically you have to include sexually active women to get to the men, let's say. And then I think that's a very clear example. I think there are other examples where it may be culturally unacceptable to exclude women, even if your main goal is to get to men. Another example is our female sex worker testing program. And it seemed like perhaps in your modeling you didn't consider that certain subsegments of populations might have more sexual contacts and might be cost effective to test. So that's kind of the comment. The question is what your thoughts are about pediatric testing, a setting where I imagine, if you identify peds, you'll have more DALYs saved, but your yield will be lower.
Hi, my name is Esther from Lesotho. I have a question for Auxilia from Zimbabwe about the index testing. You said that you're only doing patients who are newly diagnosed, and I was wondering whether you are doing the same approach for patients who've been on ART for a while. The reason being that since you're exploring partners that they've had in the past, they might have infected someone before they were put on ART. We are actually doing a similar program in Lesotho, and we're finding about 18% positivity amongst people, partners of patients who are in community ART groups, meaning these are stable people who've been on ART for a while. So just to hear your thoughts on that.
I can repeat your question? No, go ahead.
for Auxilio and Catherine, and possibly a little bit for Andrew. You keep talking about the 19-19-19, we've got to test everyone and get that yield. You don't talk about the prevention in any of your programs or models, and we know even if we're nearing that 19-19-19, we're still getting ongoing transmission. And this particularly, I mean, this doesn't seem to feature in any of this need to think about prevention and some tailored prevention, particularly for those who you diagnose as negative but are of high ongoing risk, the key populations, etc.
Last one.
Sorry, that was Rachel Bagley from WHO. Thank you.
Thank you very much.
The very last one. Yes.
My name is Andrew from Uganda, and my question relates to the self-testing. I presume that sooner or later, the self-testing is going to end up at community level and household level. Is there any information about whether these kits create medical waste? And if yes, how has this been managed? Or if they don't, can we just throw them in the ordinary bins? Thank you.
So we have a few questions. We have 5 minutes remaining, so I'm going to ask everyone to be concise and efficient on their responses. Thank you so much.
Okay, thank you, Esther, for your question. Regarding whether we are testing clients that have been identified before or the new testers, we are actually targeting both. So you'd find that when we started implementing the program, we're actually going back in time to identify all people that we on ART. And I think the time that we started our pre-ART, when actually we started the test and treat, our pre-ART register had a lot of people that were not on ART. So we actually went back to the pre-ART registers and identified all people that were in those registers for community index HIV testing. So now that we've almost exhausted from the cohort from before, we are now working with the clients that are being identified in the recent periods. Coming on to prevention strategies, as a program, you'd find that the bulk of our clients, the 62% are actually HIV negative. And as a program, we have come up with some post-testing guidance that we are providing and materials that we are providing to our clients that we identify to be living with HIV, and to clients that are not HIV positive. We have also, going forward, we are also thinking of providing PrEP, like I mentioned in my presentation, that going forward for clients that we identify to be HIV negative and they are coming from high-risk populations, we are also going to be providing PrEP as a prevention strategy. And I think that's what I can say for prevention. Thank you.
Thank you. Andrew, in 1 minute.
Thanks. So thank you for raising those points about women, and that. So the intention is not, and I didn't really get a chance to say it, but the intention is not that essentially this is saying that if you're doing those things, then under no circumstances should you test a woman, in any. But I think the fact that you were thinking about certain situations in which it might well be, which it would almost certainly still be important to test. So the intention is just in terms of overall programs, you'd want to really think about whether they're cost effective if they're non-specific about the women that they're accessing. But there's certainly going to be exceptions where there's situations where you would definitely want to be testing women. In addition to that, I should have said also that the model is an adult model of sexual transmission, and so I really can't speak about paediatric testing. It was really applied to adults. And Rachel, just to say, so we're not including the potential for using PrEP in the modelling that I showed, but we are using in the same model in other contexts and could introduce it. But we are assuming use of VMMC, but not currently assuming that testing negative leads to a greater chance of VMMC, and again that could be done, but the evidence is not huge for it.
The first question was around linkage to care, ART initiation. So because self-testing and people would conduct the self-test kits on their own and be able to interpret on their own, there was no requirement that they disclose their status. So it is very possible that someone may test positive, not initiate ART, and go back into the community. And unless they disclose their status, we would have no way of tracing them. That being said, even with that as part of the design of the intervention, we still reach 70% ART initiation. So our linkage rates are still fairly high there. But I think that that's just part of the nature of self-testing and part of the appeal of self-testing for clients that we have to deal with. The other question was about waste and regarding use, and I think specifically around community and home-based testing. I actually don't, I'm not exactly sure. I haven't done community or home-based self-testing, but there are a lot of others at this conference that may have a better sense. We didn't see a large amount of issues with waste within the facility setting. And then I think finally, Rachel, the point about prevention and not addressing that, particularly among those who are testing negative. I think that's a great point and something that is being overlooked and something that I think we need to make sure that we incorporate within all of our programs better.
Wow, thank you so much for fantastic presentations. If you're here, you must be interested in HIV testing. Tomorrow we have WHO has organized a workshop on cost effectiveness of HIV testing. So those of you who are interested in learning about cost effectiveness analysis, please do come. It's at 2:30. And I wanted to really thank the panelists. You did all really fantastic jobs, and I look forward to chatting to you all after this session. Thank you.